Hi, everyone, and welcome to the Southwest Regional Boot Camp. I'm Katie Richards, and I will be reviewing our first topic on basic bronchoscopy, covering bronchoscopy as a whole and bronchoalveolar lavage. There are a wide variety of indications for bronchoscopy. Airway inspection may be beneficial in the workup of persistent unexplained cough, hemoptysis, localized wheezing, hoarseness, suspected vocal cord paralysis or tracheoesophageal fistulas, and chest trauma or diaphragmatic paralysis. Fibroactive bronchoscopy can also be used as a tool for airway management and intubations. Bronchoscopy, along with other procedures such as lavage or biopsy, may be utilized for the evaluation of focal hyperinflation, localization and treatment of bronchopleural fistulas, and workup of abnormal chest imaging, including parenchymal masses or nodules, paratracheal, mediastinal, or hilar masses, and pneumonias, particularly in cases of immunocompromised hosts or non-resolving pneumonias. Other indications include foreign bodies, evaluation for rejection in lung transplant recipients, delivery of brachytherapy, and for research purposes. When it comes to contraindications, most are relative contraindications for bronchoscopy, and how relative will largely depend on the urgency of the procedure. These contraindications include refractory hypoxemia, current or recent myocardial ischemia, poorly controlled heart failure, hemodynamic instability, life-threatening cardiac arrhythmias, and active exacerbations of either COPD or asthma. In cases where biopsies or brushing are planned, an increased risk of bleeding due to medications like anticoagulation or antiplatelet therapy, thrombocytopenia, coagulopathy, or renal insufficiency may be prohibitive. There are two types of bronchoscopes, rigid bronchoscopes and flexible bronchoscopes. Flexible bronchoscopes are widely available and have good scope reach. However, an endotracheal tube is required for airway control, and flexible bronchoscopes have limited suction abilities. Another limitation is that you cannot suction and use an instrument simultaneously with a flexible bronchoscope. Rigid bronchoscopes require specialized expertise, but have the advantages of providing integrated airway control, excellent suction, and the ability to suction and use instruments simultaneously. However, availability and scope reach are two of the limitations with rigid bronchoscopes. As a general pulmonary critical care fellow, you will primarily use flexible bronchoscopy. As a result, this course will focus on that as well. This diagram highlights some of the key structures of the flexible bronchoscope. At the most proximal end is the eyepiece or camera head, as well as the cable for the light source and image processing. Just below this is where you will hold the scope, noting a lever to manipulate with your thumb that controls the extension and flexion of the scope's tip. There's also a suction channel as well as a catheter insertion channel, which is commonly referred to as a working channel. The distal portion of the scope is a flexible shaft which allows maneuverability within the airways. You can see a cross-sectional view of the tip with the working channel, camera, and light source. The typical length of the insertion tube is 600 millimeters with a diameter of 4 to 6.4 millimeters and a 120-degree field of view. The distal tip can angulate between 180 and 210 degrees. Working channel diameters will range from 1.7 to 3.2 millimeters. The scope can be entered through the nares, oral aperture, tracheal stoma, or through an endotracheal tube for intubated patients. Only about 10% of the cross-sectional area of the trachea is occupied by the flexible bronchoscope, which allows for easy ventilation around the scope in awake patients. In intubated patients, the scope will occupy a greater proportion of the cross-sectional area in the endotracheal tube. This procedure can be done under local or general anesthesia, but only requires topical anesthesia and moderate sedation. Next, we're going to talk about the advantages and disadvantages of nasal versus oral entry. The nasal route has the advantage of causing less gagging, allowing better control of the scope during its advancement in the upper airway, and providing better visualization of the pharynx with lower risk of trauma to the teeth or gums. On the other hand, it has the disadvantage of risking trauma to the nasal passages, causing epistaxis, and generally being more burdensome, especially in cases where you may need to be repeatedly removing the scope to clean it. The nasal route also results in greater difficulty controlling massive hemorrhage or inserting a large endotracheal tube. Therapeutic bronchoscopes are also more difficult to use through the nasal route due to their larger diameter. The oral route similarly has its own set of advantages and disadvantages. Advantages include a larger endotracheal tube through which the bronchoscope can easily be removed and reinserted, and orotracheal tubes will also allow for better control of airway and ventilation and can accommodate larger instruments for interventions. Disadvantages of the oral route include risk of damage to the teeth and gums and increased risk of gagging. During a bronchoscopy, the bronchoscopist works alongside a procedure nurse and a bronchoscopy tech. The procedure is performed in a monitored setting and can be performed with topical anesthesia and moderate sedation. One main consequence of bronchoscopy is a drop in PaO2, usually around 20 millimeters of mercury. This is mainly due to impacts on ventilation to perfusion, though hypoventilation also contributes to some degree. These effects are more pronounced in patients on mechanical ventilation, and this is due to the effects of suctioning and endotracheal tube obstruction. Overall, the mortality rate associated with bronchoscopy is very low at 0.04%. Causes of death include hemorrhage, cardiovascular events, bronchospasm, aspiration pneumonia, and reactions to medications, including sedation and local anesthesia. You can see a list of potential complications on the right side of the screen. Luckily, major complications are rare, occurring in only 0.12% of cases. These major complications include significant hemorrhage with bleeding more than 50 milliliters, respiratory depression or distress, pneumothorax, arrhythmias, bronchospasm, laryngospasm, vasovagal events, allergic reactions, bacteremia, dislodged equipment, upper airway obstruction, pulmonary edema, or laceration of the bronchial wall. Minor complications occur more frequently and include desaturation, smaller amounts of bleeding less than 50 milliliters, cough, pain, and epistaxis. It's important to note that more than half of life-threatening complications involve topical anesthesia, sedation, and pre-medications. This risk is increased if patients are elderly, have cardiac disease, COPD with hypoxemia or hypercapnia, or serious liver disease. In general, pre-medication prior to sedation is not usually necessary. Sedation is provided with benzodiazepines and opiates, and a combination of the two is preferred to either alone. Please also note that topical anesthesia itself can cause complications, and therefore it should be limited to the minimal effective amount to avoid systemic toxicity. Now that we've covered general bronchoscopy, we are going to discuss bronchoalveolar lavage, or BAL. This procedure allows for sampling of millions of alveoli, so its highest yield is in alveolar processes like infection, malignancy, alveolar proteinosis, alveolar hemorrhage, fat embolism, lipoid pneumonia, silicosis, borreliosis, asbestosis, and eosinophilic lung disease. In addition to all the general contraindications for bronchoscopy that we've already reviewed, the primary and only absolute contraindication for BAL is refractory hypoxemia. Severe hypoxemia, especially with large volume BAL, is a relative contraindication. In certain circumstances, you may intubate for the procedure to mitigate these risks. High airway pressures are also a relative contraindication for BAL on mechanically ventilated patients. So what about the potential complications? Hypoxemia is one of the major complications or consequences of BAL, and it may last for several hours after the procedure. As a result, you should consider intubation for large volume BAL in tenuous patients with borderline respiratory status. Fever may also occur after the procedure in 25 to 50% of patients, though it usually resolves in hours in response to antipyretics. You may see an increased area of density on chest imaging, and crackles and infiltrates may last up to 24 hours. Other potential complications include decline in spirometry, pneumothorax, and increased mean airway pressures in ventilated patients. The cell count from bronchoalveolar lavage can be very helpful in ruling in and out various diagnoses. The normal cell count from a BAL is 90 to 98% macrophages, 5 to 15% lymphocytes, 1 to 3% neutrophils, and less than 1% eosinophils. Conditions in which you may see a cell count with more than 20% lymphocytes include sarcoidosis, drugs, cryptogenic organizing pneumonia, lymphocytic interstitial pneumonia, nonspecific interstitial pneumonia, hypersensitivity pneumonitis, borreliosis, and lymphoproliferative disorders. In contrast, more than 5% neutrophils can be seen with acute bacterial pneumonia, acute interstitial pneumonia, diffuse panbronchitis, connective tissue disorders, drugs, and idiopathic pulmonary fibrosis. If more than 5% eosinophils are present, considerations include eosinophilic pneumonia, drugs, hypereosinophilic syndrome, idiopathic pulmonary fibrosis, Churg-Strauss syndrome, and pulmonary Langerhans cell histiocytosis. Now we are going to dive into the technique for performing a bronchoalveolar lavage. The first consideration is deciding on a location and targeting the segment. For focal processes, your imaging will guide the segment you want to target. However, it's also helpful to keep in mind that the yield is increased by performing the BAL in gravity-dependent areas. The right middle lobe and lingula tend to have the best return for this reason. Once you have reached the target segment with the bronchoscope, you will wedge your scope with the suction channel in the airway lumen. Be sure not to overwedge the scope. You will then instill room temperature saline through the working channel in serial aliquots of 20 to 60 milliliters. Protocols vary and the optimal total volume to instill is not known. However, the typical volume instilled ranges from 100 to 300 milliliters. Fluid recovery can be done in a variety of ways, including hand suction into the syringe, gravity flow into a dependent container, or gentle wall suction into a specimen container. The optimal dwell time is not known. The typical proportion of instilled fluid that is recovered ranges from 40 to 60%, and optimal sampling returns are those of at least 30% of the instilled volume. Lastly, I'd like to highlight a couple of helpful tips. First, when you are suctioning, you want to do so gently and slowly with your scope midline and the airway lumen centered in your view. Ideally, you want to avoid having the patient cough during the procedure. And of course, you want to keep your bronchoscopy assistant informed of the plan along the way. It's also useful to know that you can generally expect a lower rate of return in patients with COPD, advanced age, smoking history, or on mechanical ventilation. Overwedging the scope will also result in a lower amount of return. Lastly, it's important to recognize when you have an inadequate sample. During the procedure, you should recognize this if the return is less than 10% of the instilled volume. Alternatively, more than 2% columnar epithelial cells will also signify an inadequate sample.